hormonal drug that has androgenic effects, and it has effects on brain. It improves libido compared to others, and we'll speak about that a little bit later. If we look at the clotting risk, the overall clotting risk of tibolone, because we have to talk about it separately compared to the estrogen and the progestogens, is that tibolone really, if you look at this forest plot, is neutral, if not better, from a clotting risk compared to other oral hormone treatments. The other combination that is often used in practice is the 52 milligram levonorgestrel containing intrauterine device, in other words, the Mirena. If you use that together with estrogen, the data is very limited, but what we do know is that C-reactive protein, when it was measured as a surrogate marker, was increased, and that oral hormone therapy as opposed to the group on levonorgestrel. In other words, the Mirena is better from a clotting risk as using it as your progestogen base in women who have got a uterus. So the good thing about using a Mirena as your progestogen is that it has positive effects on your lipids, so on your cholesterol, etc., as opposed to oral hormone treatment. So what is the dose of progesterone that is required to prevent endometrial hyperplasia? In other words, uterine cancer. We know that the lowest effective daily dose in a postmenopausal woman depends on the type of progestogen that you use, but you need to use at least 100 milligrams of micronized progesterone a day, particularly for at least 10 days of a cycle. You cannot use a Kyleena loop. You can only use a Mirena if you want to prevent endometrial cancer in postmenopausal women who are put onto hormone treatment. So everybody with a uterus has to have progesterone in order to prevent endometrial cancer. Because if you use estrogen alone in somebody with a uterus, you are going to cause an endometrial cancer. So the combination is critical and key. And I can tell you that continuous progesterone decreases your endometrial cancer risk significantly more than if you use cyclical progesterone. So we prefer women not to be on cyclical 10 days a month of progesterone. We need them to be on continuous in order to prevent endometrial cancers. What about progesterone cream? Pure progesterone is not well absorbed. There is no efficacy data. In fact, we see an increase in endometrial carcinoma. There is no data on hot flushes for progesterone cream, and we have no data on VTE risk. So we prefer you not to use transdermal progesterone cream because it hasn't been passed by the Medicine Control Council as being endometrial protective. Estrogen. Does estrogen make a difference? We certainly know from a coagulation perspective that if you use oral estradiol compared to transdermal estradiol, there definitely is a difference. And if you look at various surrogate markers from a venous thrombosis perspective, we know that D-dimers are unchanged, so is protein S, so is your APC ratio, your thrombin, etc., if you use transdermal. So transdermal, if you see, there seems to be a common theme in terms of estrogen is better than oral hormone treatment. So overall, we can say that transdermal is better. If you look at estrogen, oral estrogen, there have been 8 case-controlled, 6 randomized trials, 6 prospective trials, and overall, there's a 2 times greater risk of getting a DVT compared to a transdermal. So from that perspective, we prefer things through the skin. You might say to me, why then do we ever use oral hormone treatment? Well, in fact, there are certainly a group of women where transdermal hormone treatment does not work for them. Its efficacy is far less. They seem to get really tender breasts. And in those women, we would choose to use an oral hormone treatment. What about hereditary thrombotic condition? So if you have a hereditary factor V laden, or you have a G2021A thrombin gene, basically you have a 13 to 16-fold increased risk of venous thrombosis. So we prefer to use no hormones in this group of women. And we don't screen women, we take a family history. But should we have to or need to use it in women with severe symptoms, again, we would prefer to use a transdermal, and we most certainly would not use an oral preparation. In women with lupus and antiphospholipid syndrome, again, we know they are at much greater increased risk of thrombosis. We would avoid hormone treatment in these patients, particularly in patients who are antiphospholipid antibody positive. And in those women where we really need to, who have lupus and they need hormone treatment because of protracted symptoms, again, always using transdermal. So the recommendation overall from the International Menopause Society is that if you've had a pulmonary embolus, you should not be using hormone treatment in those patients. Anybody with an unprovoked clot, it is strongly contraindicated. In people with a provoked clot, in other words, people who develop a thrombosis after trauma or a fracture, then you need to use it with caution. In people with a family history of a clotting disorder, I would suggest that you do test them. And in women with a history of migraines, you should rather use transdermal hormone treatment than oral treatment. What about hypertension and diabetes? Well, in fact, type 2 diabetes was 6.2% in women using hormone treatment versus 9% in women on placebo. In other words, diabetes improves if you use hormone treatment. And this was still significant even when you adjusted for body mass index, weight change, and weight circumference. And that changes in fasting glucose and insulin during the first year of follow-up suggested a decrease in insulin resistance and requirements. And again, transdermal seems to have a positive effect on glucose metabolism. But it is not the reason to use hormones. You don't use hormone treatment to prevent diabetes, but certainly in women who are diabetic, who have symptoms, and you use hormone treatment, you need to individualize their care, and in fact, their diabetes might be better, but you need to take into consideration their cardiovascular risk, etc. So what about women with cardiovascular problems? So menopausal symptoms in women with cardiovascular problems become difficult to manage. And we know that the timing hypothesis, it's back to that timing, that in women who institute hormone treatment early in their menopause, that seems to have a cardioprotective effect. But we don't use it for primary prevention. In other words, don't put somebody on hormone treatment if they don't have symptoms, just to prevent their heart or to protect their heart. So there's no large randomized trial that evaluates cardiovascular disease regarding different formulations, doses, and routes. So we're not sure if it makes a difference from a transdermal perspective. What we do know is that if we institute any form of hormone treatment early, is that there is some cardioprotective protection in these women. But again, it's about lifestyle modification that becomes so important. You know, it's no good just prescribing a medication if you don't change a woman's lifestyle. You need to change their lifestyle so that you can have an effect on their C-reactive protein and on their triglycerides. So the guidance really is that if you have somebody with hypertension and they're well controlled, you can use hormones. But if they are uncontrolled, then you would prefer to use a non-hormonal preparation or a transdermal. You see the common theme here, guys? The common theme? Transdermal, transdermal, transdermal. So again, women with dyslipidemia, you would prefer to use a transdermal preparation, as would you in a diabetic or an obese patient or somebody with metabolic syndrome. So where possible, try to stick to the transdermal as opposed to an oral preparation. So does tibolone, remember we said we have to talk about tibolone separately because it's a different drug, it's a different formulation. So we know that tibolone certainly does not seem to have an effect on weight, nor does it seem to have an effect on blood pressure. So it seems to have a neutral effect as far as BP and blood pressure. But brains are very important. Our brain in the menopause. What we know is, this is a fantastic article again, Nicole Jaff, our very own Nicole Jaff, together with a fantastic scientist from the US, Pauline Maki, published this white paper on brain fog in the menopause and a healthcare's professional's guide to decision-making and counseling on cognition. If you look at optimal cognitive health in a menopausal woman must be counseled about not smoking, staying connected, exercising their brain, making sure they're not overweight, to train the body and boost the brain. In other words, we should be doing 150 minutes of moderate intense aerobic exercise weekly. And we need to make sure that our diabetes, hypertension, and our blood pressures are under control in order to improve our brain health, to try and decrease that senile dementia as we age. There's conflicting data on cognition and the use of hormone therapy. We know from epidemiological studies, it suggests that women who initiate hormone therapy soon after the menopause, they have a decreased risk in dementia, and that oral estrogen improves mood as opposed to, for instance, transdermal estrogen. So here we have the opposite. Here we're saying that oral estrogen improves mood as opposed to the transdermal, but we know that oral conjugated estrogen, in other words, Premarin, combined with micronized progesterone, has much lower depression and anxiety scores than those women who receive transdermal estrogen with micronized progesterone. So there seems to be something in the oral preparation when it goes through the liver that improves the brain in terms of depression and lowers anxiety. Tibolone is neuroprotective. There is data to suggest that it's neuroprotective. Normally in menopausal women, you get a decline in your gonadal hormones, and tibolone has a rapid effect on these GABA receptors, and it may improve depression. We also know that it decreases sex hormone binding globulin, and this increases the availability of hormones and therefore improves cognition and mood. So tibolone has certainly seemed to have a different effect on the brain than other oral hormones. So sexual health. So we've talked about lots of things. It's lots of information. But what I'm saying out of all of this is that your choices, really, you need to think about each patient as an individual. And when you look at your choices, for instance, in sexual health and tibolone, we know that tibolone improves vaginal dryness and sexual function. It increases vaginal pulse amplitude and vaginal maturation index, so therefore making the vagina much more moist and improving the rugae. So sexual function improves in tibolone. And that's when you compared it to the use of estrogen with NETA. It also improves libido, and it's the only licensed hormone therapy that improves libido. And it improved libido more compared to DHEA and 17 beta estradiol together. So we see a positive effect when we use tibolone in these women. I have to encourage you to ask women about their dry vagina. We did the study where we looked at looking at vaginal atrophy and on sex and relationships. And what we found is that the vast majority of women have dry vaginas in their menopause. They are shy, they don't talk about it, and they are unlikely to be asked about it by their practitioners. So ask the question, is your vagina dry? Are you struggling with dry vagina? And are you struggling with painful sexual intercourse? Because vaginal estrogen, in fact, is a very safe drug. It is a Schedule II drug and can be bought over the counter. And I would strongly encourage that you talk about it with your patients. You can see we can speak on one subject. There are so many things that are involved in hormone treatment, but perhaps the one thing that scares everybody is hormones and breast cancer. So we know that studies suggest that the prolonged use of high concentrations of estrogen increase your breast cancer risk. But you also have to know that reproductive factors are important. The age of your first live birth, the age of your menopause, your parity, did you breastfeed, body mass index. Obese patients are at much higher risk of breast cancers. Postmenopausal weight gain has been associated with a much higher risk of postmenopausal breast cancer in a multitude of studies. So in fact, if you have a look at this forest plot and you look at patients who are overweight, you see a significant increase in breast cancer risk. So weight alone, obesity alone, is a problem from a breast cancer risk. But if you look at this from up to date and you look at the difference between estrogen and progesterone versus placebo, we certainly know that if you use estrogen and progesterone alone, the longer you use it, the increase you get in the breast cancer risk. But if you compare this to using estrogen alone, that's this line, the risk of breast cancer in estrogen alone in hysterectomized women is much less. So it's not just the estrogen. It must be the combination of the estrogen and the progesterone that seem to increase the breast cancer risk. So I'm not so sure that estrogen alone is the baddie in this whole story. Tibolone, we have to talk about tibolone in breast cancer. Tibolone, if it's taken by a woman with a personal history of breast cancer, it is associated with an increased risk of recurrence. We used to think that you could use tibolone in breast cancer survivors, and now we know that we categorically cannot use this drug in women who are breast cancer survivors. And we know that the evidence for tibolone use increases breast cancer from observational studies, and that tibolone is just like any other hormone replacement therapy, and it does not decrease the breast cancer risk. If you look at the Liberate trial, what they did was they took over 3,000 women with breast cancer, and they gave them tibolone versus placebo. What they found is that the recurrence rate was higher in the tibolone group. We thought this was going to be the drug that we could use in breast cancer survivors, but in fact, we cannot. Tibolone is the same as any other hormone treatment. You may not use it in breast cancer survivors. So what can we use as an alternative if women do not want to take hormone treatment? Certainly exercise, lifestyle modification. We can use certain SSRIs and SNRIs. We can use Neurontin and Clonidine. In the SSRIs, we know that estrogen withdrawal decreases serotonin. And what they've shown is if you use an SSRI, you can decrease hot flushes. But I want you to be wary of the choice of SSRI that you use, particularly in women who are on tamoxifen. So we prefer you not to use paroxetine or fluoxetine because this affects the CYP pathway in the liver and may affect the efficacy of tamoxifen. So those two should not be used in women who are on tamoxifen. But if you look at SSNRIs, they also inhibit the reuptake of serotonin, noradrenaline, and dopamine. And we know from some small trials, in fact, that you get a 50 to 60% reduction in hot flushes. So in those women who are breast cancer survivors, we would prefer to use venlafaxine or citralopam. It does not have an effect on the liver metabolism of tamoxifen. So it's a great choice in those breast cancer survivors who are flushing. Gabapentin can be used, as can oxybutynin. The problem with gabapentin is you have to use very high doses, and those high doses make you so sleepy and drowsy that you don't feel a hot flush because you're too busy sleeping. And oxybutynin also causes a dry mouth, constipation, and cognitive decline with memory loss. So we really prefer not to use oxybutynin in this group of women who are unable to take hormone treatment. Something that we have tried, particularly in women who have breast cancer and are really struggling with their hot flushes, is a stellar ganglion block. Our intervention radiologists do it. It lasts for 6 months. There are limited trials on it, but it is an option for those with intractable hot flushes. So my final word to you is that this is a lot of information. But what I want to say is that estrogen has a positive effect on your bone, your brain, and on hot flushes, and possibly on your cardiovascular system if you introduce it early with that window of opportunity. You have to add a progestogen if you have a uterus in order to prevent endometrial cancer. Tibolone has estrogenic, progestogenic, and testosterone-like effects. So tibolone is a good choice in women who have decreased libido because it also has a positive effect from the genitourinary syndrome, which is a dry vagina. Transdermal is best, so try and stick to transdermal. Transdermal progesterone, in other words, a progesterone cream, it does not give you adequate endometrial protection. The progestogens, which are used in the patch form, have been tried and tested, and they do give you adequate endometrial protection. So I hope I haven't confused you too much, but rather given you a sense of your choices and how you should choose your hormone therapy for each individual woman. Thanks. Any questions?
Thanks, Jude. Yeah, there are a few. Okay, do you want to, I think, stop sharing your screen for a bit? We might need to go back to it. Okay, so, okay, let's run through the questions. So the first question is, what meds do I add in a patient with breakthrough bleeds who are on hormone replacement therapies?
Okay, so we have to stop it right there.
Okay.
So anybody who is bleeding on hormone replacement treatment needs investigation. So certainly early, when you start somebody, initially, you can warn them that they might have some breakthrough bleeding. But if they are bleeding, you need to investigate them. Do they have an endometrial cancer? Do they have a cervical cancer? If you have excluded those two facts, you have to say that it is iatrogenic, it's drug-related. Then you have to, if they're on a transdermal, think about moving them onto an oral. And whereabouts are they in the menopause? Was it early? In the early transition, if you haven't missed more than 6 months of period, and you start somebody on a continuous hormone and progesterone every day the same, you're likely to get breakthrough bleeding. Then you need to put them onto what's called a sequential. In other words, you want them to have regular periods every month, and then you would only move them to a continuous combined a year later. So they need to be investigated.
And there's another question regarding venous thromboembolism.
Yeah.
And the VTE risk. The question is it due, is it not due, or is it due to the effects on the liver? And the question is, surely transdermal estrogen plus oral micronized progesterone would not increase the risk of venous thromboembolism.
Yeah, that's what we're saying. That's why transdermal is best from a thrombotic perspective, is that because of that, you miss that first pass through the liver. So yes, transdermal estrogen with a micronized progesterone is the way to go.
Another question, is it necessary to check hormone levels before starting HRT? Sorry, will you excuse me for a sec? I've got
not at all.
Okay,
yeah, go
on.
for it. I can answer the questions in the meantime. So is it necessary to measure hormones? Okay, so the answer to that question is absolutely not. And it is not necessary to measure hormones while you're on hormone replacement therapy. We do not know what an optimal hormone level is for somebody. It's about symptom control. In other words, the only time I will measure hormones is in a woman who has had a hysterectomy, and I'm not sure if she is menopausal. Then I may measure her hormones. So many patients come to me and they say, I haven't had a period for 6 months, doctor, and they measured my hormones and I have none. And I say to them, thank goodness you have none, because that's normal. It's normal in menopause to have a low estradiol and a raised FSH. If you have very high hormone levels and you are way past menopause, you have a estrogen secreting tumor. So no, it is not necessary to waste the patient's money and measure her hormones. I think you're on silent. You're muted, right?
Sorry.
Not at all.
Rookie mistake. How long do you continue with HRT for, especially when you started in early menopause?
Good question. So we used to believe that 5 years was the maximum, but now we know is that you use hormone treatment. It's a treatment. You use it for as long as needed. So I often say to patients, they say, do I still need to take it? And I'll say, well, slowly, let's wean you off. You take your transdermal and you put your cream on or your patch. You extend the period of time, see how you feel. If you're still flushing, go back on your HRT. There's no timeline. All the new society guidelines do not put a timeline on it.
Treat in the high-risk patient, should the high-risk patient be tested for factor V Leiden deficiency before starting HRT?
So when we talk about high risk, in other words, are we talking about somebody with a strong family history of an unprovoked thrombosis or who clotted in their pregnancy? I would say, especially those women were probably never on a combined oral contraceptive. So I would consider testing them for factor V Leiden or for a thrombotic thing if they are high risk.
And is that the only one that you would test for? What about protein C, protein S?
No, I think you need to test for protein C, protein S, 2010A, and so you would do a full thrombotic screen.
Okay, got it. 2 questions regarding the Mirena. Number 1, how safe is it as an intrauterine contraceptive? And number 2, how long can it stay in during transdermal estrogen therapy?
Okay, so for all of you who don't know, the new guideline on a Mirena for contraception is 8 years. So you only have to change the Mirena now every 8 years, as opposed to every 5 years. You know, if I don't know if you remember or you know that it used to be 5 yearly that you changed it. In hormone treatment, 5 years, we don't have the data on 8. So I would change it every 5 years for somebody on hormone treatment.
Okay. What is the added risk for a smoker?
So a smoker, I mean, obviously everybody should be strongly encouraged not to smoke. Smoking increases your risk of HPV and cervical cancer. So, and as does vaping, by the way. I mean, we're not sure that vaping's any better than smoking. So we certainly would stick to a transdermal in a smoker. It is not like contraceptives where, you know, oral contraceptives, you don't put, anybody who smokes should not be on an oral contraceptive after the age of 35. So you can, and I would use a transdermal.
Okay, there's a question. In fact, I also had a question. Well, not quite a question because I don't know anything about this, but anyway. So how would you start in somebody who is, let's say, 45 years old, has a uterus, has symptoms of early menopause? Where do you start and what do you give?
Okay, so I'm 45, I am getting symptoms, but I'm still having the occasional period. I would start on a sequential if I'm still having the occasional period. In other words, you can get a transdermal sequential patch. So that would give you regular periods. I would use that for 6 months, and then I would transition them to a continuous combined transdermal patch, or for instance, a transdermal cream with micronized oral progesterone. But we mustn't forget a 45-year-old can still fall pregnant. So we need to assess their contraceptive needs. So a good thing for a 45-year-old would also be a Mirena with a transdermal estrogen, because that will cover contraception, perimenopausal contraception. Perimenopausal women fall pregnant, often unwanted. And so it is a problem. So it's a good choice to put in a Mirena and use a transdermal.
Does the risk of venous thromboembolism increase the longer you use the hormone replacement therapy? Like, is there a time limit?
So it's quite interesting that your risk of thrombosis is usually within the first year of use. And so with continuous use, you don't increase your risk of thrombosis. In other words, it's when you first start and then it plateaus out. The same as oral contraceptives. You know, initially with oral contraceptives, it's in the beginning, the first year. That's why when you switch oral contraceptives, you must never take a break. You must move from one to the next in order to maintain your thrombotic risk.
Is there a role for testosterone creams?
There is no licensed testosterone for women in South Africa. The only useful testosterone is in desire disorders, in categorized desire disorders. Testosterone increases liver enzymes and cholesterol and alters your lipid profile. So we don't encourage the routine use of testosterone, because then you have to use it off-label, unlicensed, and you have to dispense testosterone that may not be passed by the Medicine Control Council, or you have to use male testosterone.
What is a desire disorder?
A desire disorder is when I no longer like you, Brian. So I'm not interested. But I do like you, but I don't really.
Okay, we'll get some testosterone. What are the price differences between oral and transdermal HRT?
The price differences. So interesting. Unfortunately, transdermal is more expensive than oral. If you look at the government sector, there are no transdermals available. So we are lobbying, like we lobby for everything else. because it is a better product to use a transdermal as opposed to an oral. But, I have many women on oral hormone replacement therapy. For instance, there's a drug that contains drospirenone. So if you have acne as a woman, a menopausal woman, if you have acne and you have male pattern baldness, then you would prefer to use an anti-androgenic progestogen, and that comes in an oral form. So, for instance, like Angelique is a anti-testosterone, so an acne-led, and when you get adult onset acne.
Truth, if someone is on oral contraception, when do you switch over to HRT?
Nice question. So, first of all, every time you see somebody on oral contraceptive, you need to make sure that they're not smoking and that it's fine for them to continue their oral contraceptives. So normally what I do is, what the guideline says is that you take it until they are 51 years of age. Then you stop the oral contraceptives and you measure the FSH and estrogen, and you tell them to use a condom on day 10. And if your FSH is above 30 and your estrogen is low, they're more than likely menopausal, but you need to repeat it in 6 weeks. And if your FSH is low and your estrogen is high, then it's whoopsie time. So you make sure you put them back on the oral contraceptive for another year.
Okay, so if a lady is still having periods, but also having menopausal symptoms.
Yes.
Okay.
So if a person is still having periods, but they've started their menopausal symptoms, there are a few things you can do. If they desire contraception and they are not smoking and not at risk, you could put them onto estradiol containing oral contraceptive. So there are two, Clara and Zoli. And so that will decrease their flushing. Or if they if they still want contraception, you could put in a Mirena and give them transdermal estrogen. If contraception is not an issue for them, you could put them on a sequential hormone replacement therapy.
What is the theory behind transdermal being a better route than oral?
It's because of the first pass in the liver. So in other words, so all transdermals, conventional transdermals, contain estradiol, the natural estrogen in your body. So the patches and the creams all contain estradiol, so they do not go through the liver and they are not metabolized in your liver. So if they get metabolized in your liver, they affect the clotting factors, etc., and that's what increases your thrombotic risk. But I must caution, I have to caution here. Many people get confused with the contraceptive patch. There is one contraceptive patch called Evera. Evera contains ethinyl estradiol, the potent estrogen. And that does get metabolized in the liver. And that does increase clotting. So I want you to think that the Evera contraceptive patch is totally different to the Everil, which is the hormone replacement patch, because that contains estradiol. So important.
Trudy, there's a question regarding vaginal creams.
Yes.
You want to just say something about that?
So you must liberally use vaginal estrogen in women who have atrophy or urogenital atrophy. So what they've shown is if you use vaginal, there's a pessary, a pill that you can use called Vagifem, and there are vaginal estrogen creams, Premarin, Synapause. Those are the two main ones. So if you, urogenital syndrome is when you have a dry vagina, increase in urinary tract infections, and you have overactive bladder and a small amount of stress incontinence. We know that the use of vaginal estrogen significantly improves those symptoms. And we use Vagifem in breast cancer survivors on tamoxifen. In fact, vaginal estrogen and the vaginal pessary are Schedule 2 OTC drugs, over-the-counter drugs. So you must ask the question and you must use it. But can I just add that being on oral or transdermal hormone replacement therapy does not necessarily sort out your vagina. So you might need both.
What do you recommend for a patient that's had a HIST and an oophorectomy? It's at an early age for whatever reason.
So then you would
before menopause.
Well, they are menopausal. You surgically made them menopausal.
I mean, age before.
Yeah, age-wise. You must use estradiol, transdermal estrogen. You do not need to add progesterone to those patients. You do not need to measure any hormones. You give them estrogen according to their symptom control. And you should do, I mean, obviously it depends why they had the HIST. If they had the hysterectomy for stage 4 endometriosis, you need to use a combination of estrogen and progesterone, because endometriosis is when the lining of the uterus is outside of the uterus in the abdomen. So you can't guarantee that it's all out. So in those women with stage 4 endometriosis, you would use the combination, or you would use tibolone, because that improves their sexual libido, their sexual function. But in somebody, for instance, that the gynae, we try not to remove women's ovaries unless we really have to. In fact, now we shouldn't be removing ovaries unless they're malignant. But if you have, or they have been removed, then we would use estradiol only.
Okay, I've got a question for the physios, or from the physios, I'm assuming. Okay, tendinopathies and tendinitis in premenopausal and menopausal women. In the person who's posted the question, she's noticed an increase in pain in the tendon, specifically gluteus, the gluteal tendon. Is the estrogen a tendon protector? And if someone is presenting with tendinopathies, should they be on HRT?
So we certainly do see an increased incidence of tendinitis and joint pain in women who are menopausal. So I do consider hormone treatment, but never in somebody over the age of 60. Because remember, I said that then it actually is a problem for your heart and is a problem for your brain. So it needs to be instituted early.
Okay. Can menopause symptoms start earlier if a woman has never had children?
We don't have data on that. So in other words, if you voluntarily had no children, in other words, you took oral contraceptives, no. But remember that involuntary infertility, they might be women with polycystic ovarian syndrome. So they will have a combination of many other factors.
Trudy, if someone has been on HRT and they stop therapy for a period of time and then their symptoms recur, can HRT be restarted?
It can be restarted. But, if you stopped it 10 years ago, you might, sorry for you.
What are your thoughts on natural menopausal remedies? Evening primrose oil, Agnus castus, etc.
So we know there's a very good placebo effect initially on all of these drugs, on all of these medications. If you speak to the gerontologists, they say you should empty pharmacies of all the things that they sell except have 2 lines, and that's the diabetic, hypertensive, and hypercholesterolemic drugs. There's a lot of placebo effect on them. And, our problem is that often breast cancer survivors take these drugs and we don't know actually what they do. So, if you're taking wild yam and you're a breast cancer survivor, it's estrogen. It's a plant sterol.
Any foods that help with menopausal symptoms?
Soya, it has
Any
a high
foods to avoid?
estrogen content.
Okay.
Alcohol, cigarettes, and spicy food.
Are there any drugs that might exacerbate menopausal symptoms?
Yeah, some of the antidepressants. Isn't it interesting? Some antidepressants actually cause flushing. I'll have to go back and look. I always have to look it up. But yeah, some of the antidepressants do cause flushing.
And the new sort of flavor of the month, that SLGT2 inhibitor that everyone's taking for weight loss, Ozempic.
Ozempic has hot flushes as one of the side effects. I certainly have seen women who take Ozempic. They do seem to flush. So yes, that is one of them.
No contraindication though with HRT and
Ozempic.
Well, that or any other drug.
In other words,
like an antihypertensive, an anti-diabetic.
No, so long as you're well controlled.
Yeah.
So long as you're well controlled. Remember, anti-epileptics, for instance, though, will increase your liver metabolism if you're on an oral product. So then you would use a transdermal. So I think, transdermal would be the way to go.
Any screening that one should do before HRT, including mammograms, endometrial thickness?
Always a mammogram. Everybody should have a mammogram before starting HRT. And you should continue to have your mammograms while taking HRT. Okay. You don't need to do any other screening, just your mammogram. Take a blood pressure.
There's a question regarding phytoestrogens.
So phytoestrogens are the soya, all of those oral estrogens. Like I said, they have a very high placebo effect.
Okay.
And are pricey.
Someone that's on tamoxifen for breast cancer, the best HRT, but I think he did
never
breast cancer. And
no HRT.
Yeah.
No HRT. Anybody who's breast cancer and on tamoxifen, no HRT.
And then there's a question regarding pap smears.
Should you do a pap smear?
Yeah.
So you need to follow the guidelines on cervical smearing. In fact, now in South Africa, we prefer you to do primary HPV testing. So we do primary HPV testing probably every 3 years, unless you are HIV positive.
Okay. And look out for Dr. Carter's webinar on cervical screening.
Definitely.
Soon to come. All right. There's a question regarding Clara in older ladies.
Yeah, so Clara is an oral contraceptive drug. It is remember I told you there were 2 drugs that contain estradiol. So Clara contains the natural estrogen as opposed to ethinyl estradiol. Clara is a good contraceptive to use as a transition, but you should not be using it as hormone replacement therapy because it's got a very high dose of estradiol. I mean, it's designed to inhibit ovulation. So it's a great contraceptive to use in the perimenopausal woman who does not have contraindications to combined oral contraceptives because it controls heavy menstrual bleeding and it contains the estradiol. So yes, a good one to use in perimenopause.
Yeah, so there are a few questions still regarding someone who's been on a combination oral contraceptive or having the Mirena and they're reaching sort of 50 and no symptoms of menopause, and what should they do?
So, I mean, to me, I think it's important that hormone, it's treatment, it's not replacement. You can't replace what is gone. If you don't need it, don't take it. Less is more in life.
So there's a question regarding, sorry, just let me look for it. Premarin creams.
Yes.
And used 3 times a week for dryness in the urethral area and causing recurrent UTIs. Is that common?
So Premarin cream, yeah.
And then a risk of endometrial cancer.
No. So Premarin cream, in fact, the proper dosing for Premarin cream is daily for 3 weeks and then 1 week off, if you read the package insert. But Premarin cream decreases urinary tract infections. It's a vaginal estrogen. It's conjugated equine estrogen. Very little gets absorbed into the general circulation. And in fact, we commonly use it in old women who have a urethral caruncle. You know, when the urethra is very red, then we will put Premarin onto that area. But it's cheaper than using Vagifem.
Can a Mirena be rejected?
Can a Mirena be rejected?
By the body?
Expelled.
Yeah.
It can be expelled, sure, particularly if you have heavy menstrual bleeding. It's uncommon, but yes, it can be.
Okay, so I'm not quite sure what rejected means in the question. Okay, never mind.
Maybe ejected.
No, rejected. Okay, so if I got the question wrong, please post the question again. We'll try to get it. Okay, risk of smoking while on oral contraception. I think dealt with that.
Yeah, after 35 and you smoke, sorry for you. You've got to stop the oral contraceptive and move to something else, or stop smoking.
Can micronized progesterone be used vaginally?
We've got no data on the use of micronized progesterone vaginally with transdermal and oral. So the answer to that from a hormone replacement therapy is no, because you'd have to use it every day. It's often very messy, and it definitely causes vaginal irritation. So micronized vaginal progesterone is used in pregnancy, but we don't have much data from a hormone replacement therapy perspective.
Trudy, would you continue with hormone replacement therapy, even perhaps when symptoms are no longer an issue, purely for bone health?
I guess, the importance of hormone replacement therapy and bone is quite profound because, as you know from ICU, elderly patients for fracture have a very high morbidity and mortality. So bone density, we should be measuring bone density at the age of 64 in all women. But there's good value, particularly in patients who have a strong family history, who are very thin, perhaps are, on thyroid medication and at risk from fracture. You can continue the hormone replacement therapy.
Okay, so there's a question regarding severe migraines. Yeah.
So, for instance, you would never use a combined oral contraceptive in anybody with bad migraine. But in fact, migraines can be precipitated in the menopause because of estrogen lack. So, you would consider a transdermal and see if it doesn't improve the migraines.
Insomnia?
Oh, good one. Hey, you and I, insomniacs. So insomnia is improved in women on hormone replacement therapy. Sleep disturbance, classically, sort of postmenopausal woman will wake up at 2-3 in the morning. So they go to sleep easily. They wake at 2-3 in the morning and then struggle to fall back to sleep again. And in fact, hormone replacement therapy improves sleep. Sleep, there's a lot of work now, and I'm sure you have read quite a lot on sleep. Sleep from obesity perspective, sleep from a metabolic perspective. And remember, hot flushes decrease your REM sleep. So that's why hormone replacement therapy improves sleep. And progesterone must be taken at night because it affects GABA receptors.
There's a question regarding menograin for hot flushes.
Clonidine. So clonidine is a very old drug. So we use it particularly in women who it's a contraindication to the use of hormone treatment. So clonidine we use 3 times a day. I use it in my breast cancer survivors quite a lot.
Okay, Trudy, there's a question. Sorry, some kind of coffee and menopause.
Coffee,
yeah,
not good.
Good.
Coffee, no, it increases flushing
and male menopause.
Yeah, it makes you grumpy, particularly if
Yes,
you
I better
withdraw
stop
the coffee. If you
Yeah,
withdraw the coffee.
with the headaches.
Yeah.
Does HRT cause weight gain?
In fact, very interesting. If you took in the trials, women who don't take HRT gain more weight than women on HRT. It's a redistribution of weight that happens in that perimenopausal. So you become more pear-shaped in the menopause. So you gain it in the midriff. That's why your abdominal girth increases and your diabetic risk increases and your cholesterol increases.
If there's a strong family history of breast cancer, would a mammogram be adequate as a screen before starting HRT?
Yeah, it would be. But, if you're getting an exceptionally strong family history, you also need to think about BRCA genes. Is there a genetic history? And in fact, in our BRCA gene patients who, for instance, have a hysterectomy or have their ovaries removed to prevent ovarian cancer risk, we use hormone replacement therapy in those patients because invariably they've had a bilateral mastectomy with a bilateral oophorectomy, then we would use hormone replacement therapy. But yes, a mammogram is adequate.
The question regarding rejecting the Mirena, it's not where the Mirena was ejected, it was where the body somehow rejected it. I don't know.
Yeah, I'm not too sure what the rejection was. So was the
Yeah.
rejection increased bleeding or was there... So in fact, the Mirena is associated with alopecia, with hair loss. It's associated with depression. And it's associated with irregular bleeding and ovarian cysts. Those are the side effects of a Mirena.
Just looking for... Okay, I'll find the question just now. Oh, okay. So altroxin and Clara, or altroxin and any HR therapy?
Yeah, it's not a problem, hey?
Yeah.
Not a problem.
Okay, could you clarify again the estrogen and progesterone patches, and the examples given are Estalis and Everol, or should it be oral micronized and estrogen patch?
Okay, so you can choose. If you the ideal is to use an estrogen patch or cream with a micronized progesterone. That's the best. But the problem is that increases cost. And so many women will say, well, I don't want to put a patch on and change it twice a week, plus take an oral pill every day. So then there are combined progesterone and estrogen patches, but the progesterone is a progestogen. So the combined patches are Estralis, is a combined estrogen and progestogen patch, and Everol Conti or Sequi. Everol alone is estrogen only, and Estradot are estrogen only patches.
There's a question regarding someone who didn't experience menopausal symptoms, but then developed osteoporosis. Would you consider or recommend taking HRTs for that?
No, because there are many bone-only drugs like, bisphosphonates or Prolia. They are bone-only drugs. So those are drugs that you would use for osteoporosis.
Is there what's the risk of stroke in HRT?
So there is an increased risk of stroke, and generally that would be in your overweight, poorly controlled diabetic, hypertensive, the one that is at risk of stroke in any case, and then you add a hormone replacement therapy, there is a risk of stroke.
If you had to pick a single HRT product, which one would it be?
Sure. That's a difficult one because I literally take each person's symptoms and their needs into when I decide on what they want to do. So For instance, in a very religious patient where they have to wash their whole body, you can't use a patch because you need to take it off every time you want to pray. So that's a problem. I think about things like libido. If libido is an issue, I would consider Tibolo because it's better on libido. If patients get incredibly tender breasts on transdermal, I would move them to Tibolone, for instance, because it decreases breast tenderness and, in fact, makes breasts easier to image in a mammogram. Like I told you, if they have acne and hair loss and greasy skin, I would use something like Angelique. And Angelique, for instance, because it's got drospirenone, will drop the blood pressure. So if they are a hypertensive, well-controlled with those symptoms, I would use Angelique. So it's very varied and individual. So it's not a one size fits all.
Trudy, do you have to change the sort of the scheduling of mammograms in patients who are on HRT? Like, do you need more frequent mammograms, or is it the same?
Medical aids will pay for every 2 years for a mammogram, but it depends on how dense the breasts are to read. If they're very dense breasts, then I may consider motivating for an annual mammogram.
Okay, but taking the HRT doesn't increase the need for more frequent.
No, you don't need to have it every 6 months. No.
Okay. What is DHEA used for in menopause?
Very interesting question.
Yeah.
So a very interesting question. There is no licensed DHEA at all. It's a very hot drug that everybody uses. It is not a licensed drug. There is in Europe a vaginal DHEA that is licensed, but not in South Africa. So we're not convinced that there is data on DHEA, robust data on the use of DHEA.
Okay, you've discussed alopecia already. I'm just running through. I think we've actually covered most of these questions. Okay, there's a question regarding someone who's been started on oral utrogestan.
Yes, which is micronized progesterone, yeah.
Okay, or Femigel.
Yes, great. Is
that appropriate?
I mean, absolutely appropriate. So utrogestan is an oral progesterone. It's a natural progesterone. So you would use that together with Femigel. In fact, it's very interesting. So I had a patient who phoned me and said her sister's been started on bioidentical hormones in the NHS. I said, really? Tell me about it. She says micronized progesterone, utrogestan plus Femigel. That is a natural progesterone and a natural estrogen licensed. So good combination.
Recommendation for symptomatic menopause with fibroadenomas.
So fibroids are not a contraindication to the use of hormone replacement therapy. And so unless they're fibroadenomas in the breast, they're also not contraindicated provided your mammogram is normal. So you can use hormone replacement therapy in those women.
And there's a question regarding benign breast lump and symptomatic menopause.
If it's benign, you can use hormone replacement therapy. There's no reason why not. It's a benign mass.
Can Tibolone affect diabetic management or control, glucose control?
No. So you can use Tibolone in a diabetic. It seems to be neutral in terms of sugar control.
Okay, I think we've gone through all the questions. Want to just quickly touch on HRT for new onset anxiety, tremor, palpitations during menopause?
Yeah, so palpitations are a very common thing that happens in the menopause. So certainly I would put somebody, provided they have no other contraindication to hormone replacement therapy, from a palpitation. It helps them with their anxiety, their palpitations, and probably improves their sleep as well and their depression.
Okay, I think we have gone through all the questions, and it's 9 o'clock. Trudy, thank you so much for your time. Thank you for answering all these questions. We're going to give out your cell number and email address so people. No, we won't.
They're welcome to mail me. I'm very happy to answer questions anytime.
Thank you. Thank you so much. All right, everybody.
All right. Lovely to see you, Brian.
Thank you. You too, Trudy. Thank you so much. Okay, so everyone, that's it. Thanks again to Trudy for a wonderful webinar. It's a huge topic, which I think you did justice to, and your question answering was superb. And I'm going to hand over to Alex, and good night. Hope you enjoyed the webinar.
Good night. Thank you, Brian. Thank you, Trudy.
Thanks, Trudy.
Thank you.
For tonight, cutoff time will be 9:10. So if you could please leave the webinar before 9:10. Secondly, if you wound up on the YouTube stream through your registration link, just please email me at alex@medtalks, medtalkz.com, just with your HPCSA number as well as the meeting ID by the end of work tomorrow. And that is it. If you have any further questions, I've reactivated the chat. So if you have anything, just put in the chat. I'll answer it as soon as I see it. Thank you very much. And if we did not get to your question, I do apologize. There were quite a lot of questions, as you could have seen. Very welcome. Very welcome. Thank you, guys. Sorry, whoever sent me this question about the email. It's not for you if you're on the Zoom, which you are on now. At a point, you went over our allowed amount on the webinar, and they were shifted onto a YouTube stream. So this is for them, or whoever was on the YouTube stream, for them to email me. You do not need to email me. So if there was some confusion there. To get your CPD points, you need to leave before 9:10. Sure, Jane. But like, you do not need to email me. That was purely for the people on the YouTube stream. And yes, the CPD points will be loaded to the HPCSA. But as Dr. Levy said at the beginning, could you please go to your profiles and make sure all your details are correct and up to date? Because we do have to send these in spreadsheets, and we need to make sure these get uploaded properly. And the system can be a bit complicated at times. So they'll be uploaded for this month in the first week of July, pretty much. A reminder, you need to leave by 9:10. Just excuse me, everybody. I just got to do something on the YouTube stream before I shut it down. Those on the YouTube stream, please just look at the YouTube chat, at the stream chat for the information which you will need to do. As for everybody else on the webinar, can you please leave the webinar before 9:10? Before 9:10. Thank you. You have 5 minutes remaining. Please leave the webinar within the next 5 minutes. You need to leave before 9:10. I'll need to get back to the Indibulele. Because the one we had scheduled for next week, the regulations haven't been published yet. The new regulations for system screening have not been published. So we're not entirely sure. Maybe in 2 weeks we might be able to, but we're not sure at this point. And we'll definitely look to get Trudy back on. You're very welcome. Okay.